All right, everybody. We are here with Dr. Erich Anderer, and I would have already walked you guys through the introduction to him, but I would love to have you start, Dr. Anderer, by just giving us a little bit of background as to how you got to where you are today, and then hopefully we can pick your brain and learn something from you today.
All right. Thanks so much. I appreciate you having me on the podcast. So, as you said, my name is Erich Anderer. I'm a neurosurgeon. The chief of neurosurgery at NYU Langone Hospital, Brooklyn, which is part of the NYU Langone Health Network. I kind of took a circuitous route into neurosurgery. I sort of started off doing philosophy in college. So, for the medical students out there listening, you don't necessarily have to be a science major or a bio major in order to go into medicine. I actually, was sort of toying with the idea of becoming a PhD and, college professor, sort of following the footsteps of my dad, who was a professor of Japanese literature and film at Columbia. So, at some point, and I'd been thinking about medicine for quite some time, but it kind of been in the back of my mind for a while. Once I graduated, I went the post-bac pre-med route, and took about a year to finish off all my prerequisites, and also worked in a lab with Dr. Richard Axel, who is a Nobel laureate. He won the Nobel Prize for cloning the genes for the olfactory receptors by accident, but it actually ended up completely changing the focus of his lab. And so that's kind of what got me interested in the brain. And then once you end up in medical school, you sort of fall into two general categories. There's like the surgical type people and the medical type people. And I was more clearly the surgical type. And so given the brain, given the bent towards, sort of surgical subspecialties and my personality, sort of the natural outgrowth of that was neurosurgery. So I've been doing neurosurgery for about 11 years, postgraduate, and I got to say, it's I love it. It's such a challenge, but it really is rewarding.
Well, so let me get this straight. You went from not being sure that you wanted to go into medical school to picking probably the hardest specialty within all of medicine and the longest training route within all of medicine.
Well, I'm a delayed gratification type personality. No, I mean, I sort of had it in the back of my mind. I mean, I took a bio class when I was in sort of fifth grade. We sort of dissected frogs, and I was super interested in, like the intestines and the brain and the heart and all these different, sort of organ systems. But I kind of had it in my mind, well, I'm going to have to like sort of give my life over to this. I have a lot of interests. Otherwise, I mean, is this something that I really wanted to do? And I think over time, and even in college, where granted, I had other interests that went outside of my studies. I eventually ended up coming back to the idea that this is something I really wanted to pursue. And so, yeah, I mean, I ended up, going a whole hog into it. It was sort of I mean, it's obviously a long training subspecialty, but it's something that I think in the end, if it's what you want to do, you'll end up being able to figure out a way to have a life and, do all the things that you want to do to be a healthy human being, in addition to doing something rigorous. So I wouldn't necessarily say that people should be off-put by a reputation of a particular subspecialty. There are
Yeah.
ways of making it work.
Yeah, and I think for those reasons, you've always been such an interesting person to me. And at some point, I would love to
I
kind of have
appreciate
the,
that.
the much bigger conversation of more focused on you. But today we're here to kind of dive a little bit deeper into cervical
Yeah,
myelopathy. And so Dr. Carvelis and I had already done this introductory piece on cervical myelopathy, which really focuses on it from our perspective. We're spine physicians. We're both physical medicine and rehab docs. So obviously we see these patients all the time. We kind of walked through some of the way the patients present, some of the initial workup that we see from our end. But really, this, from my perspective, once somebody is truly myelopathic, this is a surgical problem. And so to be able to kind of hear from you, think about it from your side of the perspective and how you see these patients, I think would be really interesting for me, but also for our listeners. And so, I mean, if that's hopefully enough of an intro to kind of give you some way to lead us into your thoughts on or on seeing
sure.
these myelopathic patients.
Yeah. So, I sort of think about myelopathy as a clinical syndrome. I mean, a lot of people, you'll sometimes see the word myelopathy put on radiographic reports. Usually it's something like suspect myelopathy or consistent with myelopathy. But you really can't diagnose myelopathy on a film, right? Myelopathy is something clinical. And the word essentially means pathology of the spinal cord, which is distinct from radiculopathy, which is sort of a nerve root problem. And it's an important distinction, and this is why it's important to sort of understand the clinical presentation of myelopathy versus something like radiculopathy versus just normal axial neck pain, because myelopathy is something that I sort of think of almost as a minor festering spinal cord injury, which is something that really needs treatment. And usually, unfortunately, it involves surgery because, I'd say the vast majority of the time when I see a patient, I'm trying to figure out a way to have them avoid surgery if possible, or giving them another route, prior to embarking on something like that. But myelopathy really as a minor, being that it's a spinal cord process that involves compression of the spinal cord, generally means you need to decompress the spinal cord. Radiculopathy is something you can often treat non-surgically, and I'm sure you've talked about this, on previous episodes. But things like anti-inflammatory medication, core strengthening exercises, injections, those help. With myelopathy, it's a little bit less, sort of clear cut that those things actually do help. So that ends up being something surgical. Now, that being said, you also have to understand what the clinical syndrome of myelopathy usually entails. And the problem with it is that it can oftentimes present very subtly. It can be, start off with just like a little bit of hand numbness. Who hasn't woken with numb hands at some point in their lives, So it's something progressive. The symptoms can be subtle, but once you start to see, let's say, not just hand numbness, but let's say, loss of dexterity, increasing difficulty, with normal activities requiring fine motor control, things like buttoning your shirt, your handwriting, although nobody really writes things anymore, right? Let's call it like your texting fingers, like, your texting ends up becoming less dexterous. You're off balance when you walk, almost like you've been drinking when you haven't been, things like that. Once you start noticing those things, and especially if you're somebody that's older, who has arthritis or some other, potential reason for having things crowding the spinal canal, that's when you sort of are going to have to start taking a deeper look. And I don't know if you've gone into how to diagnose and all that, but MRI really is the gold standard for myelopathy. And at that point, you're probably going to want to engage a surgeon if you see spinal cord compression.
Yeah, and we did kind of talk about those presenting symptoms, from how we tend to work up patients as PM&R docs. We tend to utilize the electrodiagnostic evaluation. So we see a lot of these patients coming in for other things, right? For specifically that hand numbness,
right?
With loss of dexterity, who has numbness. We do a nerve study. It's a mild carpal tunnel, which wouldn't provide that significant of symptoms for somebody.
Exactly.
Usually at that point, it's occasional numbness or something along those lines that rarely interferes with life. And so then, the workup starts of how do we start to figure out exactly what's causing problems for these patients. So yeah, following up with the imaging, being able to see what the degree of stenosis is. From the neurosurgeon's perspective, when do you feel is the most appropriate time for that patient to kind of make their way over to you, right? So say, somebody, starts seeing this loss of dexterity. I know there's been numerous studies that have talked about the misdiagnosis of carpal tunnel in these patients, but we say they do come over for a nerve study. We see that it's mild, doesn't make any sense for the degree of symptoms they're having. Is that the most appropriate time for them to find their way over to you?
I think it is. It's certainly once you've gotten an MRI showing that this numbness, the working diagnosis is cervical spondylotic myelopathy. Because the thing is, given that this is a surgical disease and it involves compression of the spinal cord, which actually works by two mechanisms, right? So when the spinal cord is compressed, what can happen is you can have direct injury to the spinal cord itself. So that's kind of like the spinal cord injury part of it. But then there's also a more subtle thing going on where the microvasculature, the blood vessels that feed that area, can also become ischemic. So in other words, the spinal cord can actually lose blood flow. And so those are the two processes by which we believe this sort of starts to cause a problem. And, really the only treatment for symptomatic, I'm talking symptomatic, not just something you see on an MRI, but something that has symptoms with this compression, really the only thing is decompression. Now, there's a lot of sort of talk on what the best surgery is to do, timing of it and such, and whether or not there is a role for non-surgical treatment. And I would say that if you have somebody that's got an MRI that shows spinal cord compression but no symptoms, that doesn't necessarily need a surgeon. And if it's somebody that I saw because they got sent to me for spinal cord compression but no symptoms of the syndrome of cervical myelopathy, that's somebody I would tell you don't need surgery. And if they have no symptoms, I'd say you don't have to do anything. If you have a little bit of neck pain, maybe go see my friend Brian Joves, or do some core strengthening activities and that kind of thing. But once you start to develop symptoms, the thought process is typically this is an unrelenting course. Typically, not always. There's some literature that says anywhere from 10 to 20% of people can develop symptoms and just have them plateau. But by and large, the majority of people do tend to slowly worsen with time. And the worse you get, the harder it is to get you back to normal, even if you have surgery. So by and large, surgeons tend to once you become symptomatic, want to operate on you when you are mild to prevent you from getting to the point where you're really bad. I mean, I had a patient that came into me that had kidney disease and some other, reasons for having like a peripheral neuropathy, numbness and all, that ended up, kind of getting bounced around from doctor to doctor for 3-4 years. And he came to me in a wheelchair, literally quad. He couldn't move anything. I mean, he had a flicker of stuff in his hands, but otherwise it was a quad. And probably should have had surgery 3 years ago. And he ended up getting back something, but he had a permanent neurological deficit. He was able to walk again, thank God. But, the point is that you don't really want to get to that point. You really want to get to people early once they become symptomatic, to prevent them from getting to the point of sort of no return from a neurological standpoint.
Yeah, I think one of the things that's really challenging when we think about cervical myelopathy, and you look at some of the data that's out there, I think it's been published that the average patient with cervical myelopathy, sees somewhere between 3 and 5 physicians, over a 2 to 3 year window. And so the case that you just talked about, unfortunately, isn't a one-off.
Nope.
It is kind of something that is seen pretty regularly.
And you see it really often too, right? Someone will come in like with neck pain or something, and maybe a little hand on this, and they've been told they have carpal tunnel. Like, here, can you do something? Inject their wrists or something. And you're like, wait, well, this doesn't exactly make sense.
Yeah, and that's where I'm very grateful to have the skill set to be able to do the EMGs like we talked about. I find them extremely valuable, especially in this setting. But I think for just about everything that we're working up, because there are so many disease processes that can cross over and have similar symptom sets, and some of the things are very minor, and some of the things are much more concerning, and that need to be addressed much more efficiently and dramatically.
Absolutely. And just to kind of harp on the clinical presentation, just for those out there that are practitioners that may see a patient with this, neck pain doesn't necessarily have to be there. There was a study published a couple decades back that said that only about 20% of patients actually, or 20% of patients did not have neck pain. So that doesn't necessarily even have to be a component of the syndrome. So what you're looking for typically are either slowly progressive or sort of stepwise progressive hand numbness, loss of dexterity, loss of fine motor control, balance difficulty, so gait instability, sometimes bowel bladder symptoms. And then when you're seeing them as a practitioner in the office, you're going to want to look for long tract signs. So basically the signs that that indicate there's some kind of upper motor neuron dysfunction, implying spinal cord, not lower motor neuron, not peripheral nerve, not radiculopathy, spinal cord. So what you're looking for, one thing you can have them do is move their head, their meat sign, right, which would be like shock-like pain down the spine from flexion. But then hard signs would be things like brisk reflexes. You can do what's called Hoffman sign, where you basically flick their finger here, and the thumb will kind of do this. That's an abnormal reflex. Babinski sign, the sort of the swiping up of on the bottom of the foot with the upgoing toe. Those are things. If you see that, that's a hard sign. That's somebody, unfortunately, that is going to need surgery. And then once you see those things, typically the course ends up being unrelenting, and those are the people that we will usually recommend surgery for.
So, for the patients that are a little bit shy of that part, so say we don't have upper motor neuron signs, we see an MRI with cord compression, they have maybe a little bit of numbness in their hands, and they're talking about some balance challenges, but they also have a peripheral neuropathy from the diabetes that they've had for the past 20 years. Um, if as somebody who is seeing these patients or has this patient in their practice, how often do you feel is appropriate to have them screened by a specialist, right? And so, I mean, I would imagine that, for you, it's probably a little bit harder with the way that hospitals and clinics run to really have these people regularly seen for you to be able to do that monitoring.
Well, actually, the patient that you described just now, I'd be a little more concerned about because, there are people with diabetes that can mask this. And a lot of times somebody that is wildly myelopathic will come in, even see neurologists sometimes, and, they won't have brisk reflexes because the diabetes blunts the reflexes and all. And it is, you're right. I mean, it can cause a peripheral neuropathy that can mask some of these symptoms, the hand numbness, the foot numbness, that stocking glove distribution. So in that kind of patient with progressive hand numbness, diabetes, bad peripheral neuropathy, and spinal cord compression, that's somebody I think that should see a specialist, because you want to sort of parse out what part of that's diabetes and what part of that is, cervical myelopathy. But in your average patient with, let's just say, hand numbness and spinal cord compression, I would say they probably should see a specialist, some kind of spine surgeon, just to kind of have them plugged in. With only hand numbness, you could make the argument that that's mild. And if they don't have hard signs, like the brisk reflexes and the Hoffman sign that we were talking about, you could make an argument to sort of see where people go with non-surgical conservative management. Because, as we mentioned, there are people that plateau and don't progress. And I have a few patients like that I'm following, that have very mild symptoms. Even some of them have horrible spinal cord compression on MRI, but don't really have bad symptoms whatsoever, and aren't super excited about surgery, or have medical comorbidities that make surgery somewhat difficult, or fraught for that reason. It's not unreasonable for very mild myelopathic patients to watch them for a little bit. But at the first sign of any kind of downturn, that's usually when you would recommend surgery.
Now, what if we took a step back, kind of as we're from that patient? So let's say they have none of the actual objective measures of myelopathy. So they strictly, pretty significant cervical stenosis, no hand numbness, overall pretty, doing pretty well. This is a patient that somehow ended up with a cervical MRI that shows the stenosis. The primary care doctor gets worried. They send them over for you to see them. How do we counsel this patient, and what's the appropriate way of continuing to monitor that patient?
Sure. And I think it's reasonable for that patient to get sent to someone, just to reassure them that they don't need surgery, because that person you're describing does not. Somebody with, and it gets back to the whole idea that, cervical spondylotic or cervical myelopathy really is a clinical syndrome. It's not a radiographic one. So yes, stenosis on spinal cord compression due to stenosis on an MRI is concerning to a certain extent, but it's a picture, right? It's just it's a radiographic image. The only thing that matters really is what a patient is presenting with. In the case of somebody that got an incidental MRI or an MRI for, let's say, very non-specific, like neck ache kind of thing, but that has spinal cord compression, then I would counsel them that, look, I mean, you have arthritis, so does about 75 to 90% of the population out there. This may never become a problem, but the things I'd like you to look out for, I'm not telling you to go and live in a bubble and to like never, work out again or never do anything ever again that's going to stress yourself or stress your neck. But, you have to be careful. I wouldn't engage in contact sports, or things that would cause you to sort of, have violent motion of the neck. Short of that, I would say go ahead and live your life and just remain vigilant of your symptoms. So things to look out for would be the hand numbness, the difficulty with fine motor control, the gait instability. And as soon as you have any of those symptoms, come to see somebody. But that doesn't necessarily mean that that's going to happen. It's just something to be aware of.
Now,
But I
when
would
you're
not tell somebody, yeah, that they need to, continue on following with the surgeon.
for those patients, I mean, I think there's some literature that would suggest that maybe about 1 in 4 of those patients over the next few years starts to develop symptoms and
Right.
starts to degrade. How judicious do you? I mean, obviously, giving them the return to clinic signs, but is there a certain set of that population that you might you know either say you should see somebody every 6 to 12 months to just to continue monitoring, or something along those lines, or is that something where you kind of leave it at the patient's discretion and say, you know what, these are the symptoms, be aware of them. 1 out of 4 people may have worsening symptoms with these types of imaging findings,
Mhm.
and we'll kind of be here if you need us.
I think what you just said is sufficient for most people. Where you're really concerned, if there's something else that could potentially confound things like a diabetes, or, if, like, for example, if somebody has spinal cord compression with signal change within the cord, which usually is a much more sort of, that finding is usually much more tied to myelopathy, the syndrome. If you see, sort of T2 hyperintensity or signal change within the cord, I kind of describe it to patients as like bruising within the spinal cord, either due to what we were talking about before, that compression, or the loss of blood flow into the spinal cord. If I see that and they literally have no symptoms, which is not uncommon, not common, but I do see it on occasion, that person I might have come back every 6 months or so for a little bit, just to make sure that really they continue to be asymptomatic. But the majority of people with spinal cord compression that don't really have symptoms, I think, sort of the spiel that you gave is pretty much the same one that I give, which is that, there's a chance that you may deteriorate at some point. Remain vigilant of your symptoms. But if you don't have any of those symptoms, this is not necessarily something you have to worry about getting treated for, have surgery, prophylactically for, or anything like that. Just, kind of, I would just live your life.
Oh,
And
and
yeah,
that's
we're here if you need us.
Yeah, I think that's really good for patients to hear, and even for a lot of the providers to hear, because I mean, I think it
Yeah.
is something that, if you're not looking at MRIs, if you're not seeing spine patients on a regular basis, it can definitely be a pretty intimidating structure, right? I mean, the spinal cord is a pretty important thing.
Mm-hmm.
Maybe, I'm sure I can offend a lot of people, but maybe only second to the brain in terms of our function and quality of life, as
Sure.
anatomic structures. But I mean, I think there are a lot of people that get very concerned, right? And so when we're thinking about MRIs, which is a fantastic modality, but obviously it isn't always correlative to the symptoms the patients are having. I think we've all become accustomed to seeing on lumbar MRIs, okay, X number percent of patients have these findings without any symptoms, and these are accepted in the normal population. But at least here locally, we don't usually see radiologists put any of those disclaimers on cervical MRIs, and so I think it does
Mm-hmm.
become a little bit more challenging when people see it.
Absolutely. And, again, it just kind of goes back to our original point, which is that, an MRI is just a static image. It's, it has utility when you're looking for something specific, but in and of itself, it doesn't really tell you a whole lot. I mean, it's really all about what a patient presents with, what their clinical syndrome is, if any, and their symptoms. MRI findings are just MRI findings. And what you were talking about, lumbar disc herniations, I mean, this is going to be a long-term thing of sort of unwinding general popular belief that disc herniations are the cause of all back issues. I mean, I'm sure you've talked about on your podcast before, I mean, most of the population has some kind of disc disease at some point in their lives. And there's no real strong evidence tying that to, let's say, back pain, in any sense, unless there's other kind of neurologic symptoms associated with it. So yeah, I mean, I would say my only caveat is that obviously spinal cord compression can cause a syndrome, which is more serious and potentially more functionally debilitating. So I don't think it's necessarily inappropriate for people to have, their hackles raised a little bit when they see the words on an MRI report. But That being said, spinal cord compression in the absence of significant clinical symptoms that correlate to it really is just a radiographic finding. It's nothing that we're necessarily going to act upon, nothing that's inherently dangerous unless there is some kind of clinical syndrome which is being caused by the compression.
I think that sums it up pretty darn well. One of the other things that I think, from the interventionalist perspective, we start to think about, and I know I've had this conversation with a number of my colleagues, is that maybe going to the other end of the spectrum of these patients, a patient that is symptomatic, but has, multi, variant disease processes, significant comorbidities, maybe a, late 80s, early 90-year-old patient, that, there's a lot of other challenges with trying to manage this patient, and who frankly may or may not actually want to undergo, something
Right.
that sounds pretty daunting, right, in terms of a spine surgery.
I totally hear you, and I think that's right. And certainly medical comorbidities, quality of life, all these issues, absolutely have to be taken into account. You also want to sort of take into account the fact that spinal cord problems, myelopathy itself, can be a quality of life issue, and that should be part of the calculus. And I have operated on people that were, about 90. Because as you know, there are certain people that are 90 that are biologically a lot younger, and certain people that are 50 that are biologically more like 90-year-olds. And so a lot of this has to be tailored to the patient. If somebody is absolutely not a candidate for surgery, you're in a difficult situation because the majority of these patients do progress, and so patients just have to be aware of that. And I would say that, if you're going to go the conservative route, meaning the non-surgical route for somebody with cervical myelopathy that doesn't fit into a surgical category, then what you're going to hope essentially is that person is somebody that's in that plateau group, meaning that hopefully they don't progress. Because if they do progress, there really isn't a whole lot, unfortunately, outside of surgical decompression that has been shown to significantly alter the natural history of cervical myelopathy once it becomes progressive and causes a neurological and functional decline, unfortunately.
Yeah, I think that's the patient that, is really challenging for all of us, right? And I
Yeah.
mean, and that's one of the ones that I know when I'm sitting up talking to my partners here in our practice, and
Yeah.
it's like, this patient that we know needs something, we can't really get them to it, and trying to figure out how to help, because like you said, it's function. Unfortunately for a lot of these patients, it does become really significantly pain limiting as well.
Mm-hmm.
So trying to help manage that, but then the comorbidities limit you from, not just from surgery, but from some of the interventions that we can provide,
Mm-hmm.
and realistically from a lot of the medication options too. And so it does become a very challenging patient.
It does. And these are definitely things you have to take into account. You can't just say like, oh, spinal cord compression equals operation. I mean, there are lots of other things you have to sort of consider, when you're counseling somebody. You also take into account the complications of surgery. I mean, these surgeries are not without complication. I mean, they're fairly common. And, I think that we've gotten really good at technique, in terms of how we treat this. And sometimes you'll tailor your technique based on a patient, and based on, sort of a risk profile. But all surgeries have risks. And so, when you're discussing that kind of thing with the patient, that obviously has to be part of the calculus.
Now, when maybe just to kind of take that a step farther, when you're talking to patients about
Mm-hmm.
these surgical interventions, and specifically cervical decompression,
Mm-hmm.
one of the things that I've always been seen in my practice, is that it's generally speaking one of a very successful surgery, right? I mean, it's a quality of
Mm-hmm.
life operation, and patients tend to respond the way that we hope that they're going to respond. From your side of it, where you're the one who has to, specifically counsel the patients on that, how do you talk to the patients about that?
I mean, I think you're right. Although the recovery oftentimes is not as dramatic as, let's say, sciatica from a lumbar herniated disc. Somebody comes in with sciatica from, let's say, an L5S1 disc. They're usually horrible burning pain in one particular nerve distribution. They have pain right up until the day of surgery. They have the surgery and they're better almost instantaneously. A lot of people will have, some residual symptoms here and there, but by and large, it's like a, sort of a light switch going off and on. It's like pain, no pain, boom, you're a lot better. it's much more dramatic than what happens with this typical cervical spondylotic myelopathy patient, which, as we're saying, the symptoms can sometimes be subtle. So it's not, and it does take a while to develop. So these aren't the kinds of surgeries that you have and then boom, you're running a marathon. What happens is it sort of halts the progressive decline. So that difficulty you're having with walking, the hand numbness and all, does tend to arrest and then slowly improve. But I do tend to tell patients, because oftentimes I think a lot of surgery is expectation management. If you tell somebody that they're going to be up and running within a week, then they should expect to be up and running within a week. And I wouldn't necessarily tell somebody that if I didn't believe it. So with patients that have this issue, I feel like the symptoms are a little more subtle. They can be functionally debilitating, but they oftentimes do take some time to improve. So I'll have a lot of patients that have the surgery, and then we'll say things like, I have a lot of neck pain, but actually I noticed the hand numbness isn't quite as bad as it was before. And then the next time I see them 2 weeks later, they're like, my walking's okay, feel a little bit better. Then I see them 3 months from now. And for their first x-ray to look for the fusion, because most of them unfortunately do need fusions, they're like, oh, my walking is significantly improved, but it takes a couple of months. But it isn't quite as dramatic as some other pain for nerve pain. So surgeries for nerve pain. This is a little bit more subtle. But yes, by and large, I would say that it's a pretty successful surgery, and most people experience a significant functional improvement afterwards.
Yeah, I think from my perspective, when I tend to see that, I usually have that much larger window
Yeah.
to see the patients, right? And
Yeah.
so we're not generally in those 2, 4, 8-week follow-ups, and so
Right.
when we're seeing them separated, it tends to be months separated apart, and so we see them, it's like, oh, look, you're walking significantly better now. We can actually focus on some of these other things that are bothering you.
Yeah, I mean, like that patient I was describing before that came into my office in a wheelchair, quadriplegic, basically. When I saw him three months after the surgery, he walked into the office. It was amazing. He had a cane, but the guy was virtually a quad. It was very gratifying to see that. So it can be dramatic.
Oh, well, I think that upbeat is a fantastic place to end the conversation on cervical myelopathy. I appreciate your time giving us this education, especially the perspective from somebody who is providing this life change for patients. I really appreciate you.
Thanks so much for having me on. It was really great talking to you.
Awesome. And if any of our listeners want to reach out to you, is there a place where they can find you regularly online or anything along those lines?
Sure. I'm sort of like semi-active on social media. I'm on Instagram, Dr.Erich Anderer, DrErichander. And you can also find me on the NYU Lango and Health website.
Awesome. Well, thanks again for your time, and hopefully we can have a conversation again in the future, less topical and maybe a little bit more about your journey, just because, like I said, you are a very interesting man, and I would.
You want to talk about the rock band? Is that what we're saying?
Yeah. I would really like to start with that as the main part of the conversation next time.
Sounds good. I'm up for it.
Awesome. Well, thanks for joining us, and we'll talk to you soon, everybody.
I appreciate it.